My name is Jill Phillips and I'm the creator of Whose Shoes, a popular approach to co-production. I was named as an HSJ 100 wildcard and want to help give a voice to others, talking about their experiences and ideas. I love chatting with people from all sorts of different perspectives, walking in their shoes. If you are interested in the future of healthcare and like to hear what other people think, or perhaps even contribute at some point, Wildcard Whose Shoes is for you. So in this episode, I'm picking up the conversation that I had in episode 58 with Dr. George Winder because I enjoyed it so much. And you may remember that he told the story about V and how for the cost of a pair of shoes and some gloves, she was able to effectively come off medication that she'd been taking long-term for mental health, get involved in a walking group, and basically transform her life by becoming a local leader and then moving on and doing a university course and having a trip to China. So picking up the story there, this is how our conversation went. And it just made me think of it when you were talking sort of in passing really about V and the walking group. And I remember when I went up to Alvanley in Stockport, I actually joined a walking group.
Yeah.
From the GP surgery that happened to go about a mile and up a hill and stopped off at a cafe, and we had a couple of retired people playing the guitar to us, and we had a few songs and that. And the fact that I'm talking about it years later, these things are enjoyable, and whether you talk in terms of mental health or well-being, they're good for people, aren't they? All of us.
100%. And if you look at the international studies of what make people live longest, there are some obvious things like vaccination, stop smoking, stop drinking, but social interaction and having meaningful social contacts are huge. There's some really interesting studies, particularly around the Mediterranean, where there's longevity and social contact.
Yeah.
It's one of the most important things. We recognise that loneliness is a huge problem in all communities, and anything we can do to reduce loneliness. And I think lots of the things that we do, so we have chair-based yoga.
Yeah.
We have Pilates. One of our GPs does Pilates. She comes to do Pilates because she sees the impact that makes. We've got 2 what we call move to music groups. They're oversubscribed. We've got 20 people. It overflows. And you talk to people about why they do that, because for lots of people going to the gym, which is only 200 yards down in the local council gyms, they don't feel that that's an environment that they are welcome or feel comfortable to go and use. And some people go on from that. We always wanted it to be a stepping stone. Start doing this and then get the confidence again, feel the endorphins, feel how much good it makes you do. And I've no doubt, we don't track it well, but I've no doubt that lots of people. But also, the walking group come back for the coffee morning. We've got fast walkers, slow walkers. They meet separately now, not just for surgery. And they're friendship groups. They're people who look out for each other, people who will help each other if they're struggling emotionally or physically or need something to do in the house, or the social networks that they've built is unbelievable.
Yeah, I think that was exactly what I was going to say. You know, the more subtle things that might not be measurable, but the friendships and so on that come from it. I mean, you mentioned Pilates, and I'll tell you a little personal story because it's relevant. So I had a breast cancer experience last year, and as part of that, I was offered peer support, and I would have run a mile. There's absolutely no way that I'd go along to something called a peer support group. But actually, they set up a Pilates group, and a group of us went along because Pilates is good for you, and we did a bit of stretching and we got to know each other and we made friends. And then after the Pilates group, we have coffee together, and obviously that forms a proper peer support, and you naturally pair up with the people that you've actually got a bit of a shared story with, or that you get on better with, or you have a bit of a laugh with. And, you know, I can see that running through all of your work, George. And, you know, I suppose that's why I'm so passionate about sharing these stories. I think the story of V is a little kind of, what would you call it?
It's not a microcosm, but it's a snippet. It's a snippet of a larger pie.
But it's a great story, and there are so many of them out there, aren't there?
Yeah, and other places do this. It's just how do we scale it up? And I guess that's the point about scaling up the
Yeah.
social prescribing, you know, I worry about some things are good at scale, some things aren't good at scale. And
Yeah.
part of this and part of working with communities is that they feel part of their community. And as soon as you take it out of their community, as soon as it's not for their community, but that reciprocity, that sense of, you know, I'm volunteering, I'm giving
Yeah.
because I'm part of this community. And that, I think you have to do that. And there's real risk.
Yeah.
Moving out of communities at that level. These are the things that are best done at relationship level, people level.
This is the dilemma, really, isn't it? I mean, this is so like my Whose Shoes work, that people might see the effect of it and think, oh, we want a bit of that. But unless you actually understand the relationships and the valuing people and the way you invite people along to an event and the kind of love and care that goes into it and that local ownership, we encourage people to put their own stamp on it and come up with their own sort of introductory activities, or we have a little pledge card, and rather than having just a standard one, you know, you get different creative people enjoy developing one for that service. And that's what brings the kind of human element in, rather than just a package that works.
100%. And we found where the greatest success has always come from people's own. We want to talk to the ones that were a young mum and toddler group, because one of the volunteers' daughters had postnasal depression and didn't have access to support in the community. So we ran it, this coincided the baby clinic. It was just a place where people didn't have to go and have posh coffee and cake, but they could just drop in with fried cake and other things. And that was hugely successful. And then we had a retired teacher who was interested in supporting families where English wasn't their first language. And by the end, it hasn't got going again for lots of really sad reasons, largely because of the pandemic. We had to buy more chairs. We got 30 plus chairs because there were so many kids coming to these reading groups. And then we had students coming and doing supported reading. So we had medical students want to come and work at GP practices to get experience to get into medical school. And we said, well, you can't do that, but you can come and work in our reading group, and English isn't great. So that was amazing. You said,
meet some real people.
And that teacher in the pandemic continued those reading things. And I remember looking out into the car park with her stood under a boot over the top of her in the pouring rain, hanging out tablets and books and reading books to the kids in our community during a pandemic. Yeah, and through some tragedy, that hasn't got going again, because that was her passion. But her passion grew that, you know, this is what I'm saying. That's got to be driven by people where they recognise that, they see that commitment, they have a passion. It wouldn't work if I just said, can somebody come and run this group?
No, not at all. And I think you touched on it a little bit. I mean, I think I'm very interested as well with those kind of informal things, the stuff that gets in the way. So I remember we did an exciting mini project that I think you'd have enjoyed called Mind the Gap. So Coventry, my local town, amazing voluntary organisations there, in particular Grapevine I worked with, and we did a quick sort of Whose Shoes session around Mind the Gap, was the gap in Coventry between the services that are available and what people need. So it threw up all sorts of things, very similar to what we're talking about today. But I remember particularly, talking about these reading groups and different things. And there was a guy there and he got a bit sad and he said, we used to run a football group, but it just became so difficult because suddenly we needed different qualifications or different checks, or all the kids have got to be taken in the right size car seats and parents can't share in the same way. And you just felt this kind of layer of stuff falling down upon community activities that have been going, they weren't a problem when my children were young, but some things that are obviously meant to help, and health and safety and so on, just kind of get in the way a bit sometimes.
Absolutely. And it's a real challenge, that, because for some of those things you can see absolutely, you absolutely understand the why, but again, people are coming to harm because we're not doing stuff, and you've got to look at both sides of that. I think people look at risk unilaterally. You talked about different perspectives, and there are different perspectives on risk, and sometimes risk aversion creates harm because things don't happen, and I think that's a real balance, and I see it from both sides.
Yeah, it is a balance. But you did come up with a quote, which I wrote down: inactivity can be as dangerous as activity. And it's that, isn't it?
Yeah, it is.
That you knock out the things that might be dangerous or that might be, not proper or whatever, and what do you actually end up with? And if you make people disillusioned in the process, and things that they were passionate about or volunteering to help with, they become, it's all too much trouble, then you lose the people who are the leaders, don't you?
Can I share one of it's about working with community partners? And one of the things we recognise where working with public health is in Seacroft and surrounding areas where I work, more people have strokes.
Right.
Incidence of strokes is more. But the number of people diagnosed with high blood pressure is about the Leeds average.
Okay.
And what that suggests to us is there are people without a diagnosis in hypertension, so high blood pressure, because high blood pressure leads to strokes. And if you reduce blood pressure, you reduce the number of strokes. So there's a presumption, but a fairly reasonable one, that we're missing quite a number of people living with high blood pressure who then may later go on to have a stroke.
Right.
And so we're doing some work to see how we can do something about that. And that's based with our third sector partners. It's with our PCN team, who've got a proactive team. And their aim is, as the name suggests, to be as proactive as possible for groups who need exceptional care. And one of these groups is largely people who've been invited to the GP practice for NHS health check schemes and other things, who for whatever reason aren't coming for, might be because they work, might be because of transport reasons, might be inertia for whatever reason. But we're keen to do something, because if we diagnose blood pressure, reduce blood pressure, we'll reduce strokes. And one of the things that became apparent when we're doing this is the amazing opportunity we can by accessing people in different environments. So, for example, again, looking at people who might attend food pantries, people who are attending other community spaces where they're not also accessing GP practices and other things. And we've seen very much in the early days of this where we've rung up from GP practices, please come and get your blood pressure checked. Very little engagement. We're going out, and our third sector partners are working with the community when we have a few already people with undiagnosed blood pressure at high level that we are likely to reduce their chance of having a stroke by 20 or 30% very quickly.
Brilliant.
And what's been really interesting is about people's fear of taking a blood pressure. So blood pressure machines now, 10 or 15 quid. Now we buy them at bulk, much cheaper than that. Give them out, press a button, it's pretty safe. But people are so worried about taking someone's blood pressure or doing something that they're then not doing it. And okay, so we could just come in and get it done. It's okay, we can manage with what it is. But there's a real fear of finding something and then not knowing what to do with it. Again, I understand that. But it's really interesting that that's stopping. It's stopping things being done, because everyone's like, no, but if it's raised, what do we do? And I'm like,
right,
it was raised 5 minutes ago. You haven't raised it. It was just raised. And now we can help people go and confirm whether that is. And I understand why people are worried about it. And also we need to be careful of not medicalising other people's normal community spaces.
Yeah.
And that's a challenge. But it was really interesting about, but now we know, and I keep thinking, that's great, we know.
Yeah.
Isn't that brilliant? We're not caused any. We've just found it. And so what that work has widened lots of people's perspectives. And what's really impressive, we've got two staff members who we found, because, and these are people you'd think would be turning up for health checks and stuff, but they've got busy lives, got families, they've got other things, just like me, and
yeah,
a bit disorganized. And so it's been really impactful. We went to a community event held by one of our key third sector partners today, and we took 67 people's blood pressure who haven't had blood pressure done in the last 5 years, who should have had it done, just at one morning, with some of our coordinators just going around with the machine. Okay.
Fantastic, yeah. Rather than 67 10-minute appointments that someone's got to sign up for and come along and see somebody.
Yep. And the other thing, I guess, is the wider engagement with third sector partners has led to a high level of trust.
Yeah.
The softer conversations around saying there are different ways we can do that, and it's changed our approach to supporting communities who traditionally can't access. And to go to that question, is the NHS accessible to all? No. And there are organisational, institutional barriers to that. The movement towards everything via a smartphone, everything via online access to GP surgeries. I'm going to tell another story, if that's all right.
Yeah, do. I like your stories, yeah.
Well, I'm looking us to be on what's called a Poverty and Truth Commission in Leeds. So we're working collectively as a set of what we call civic and business commissioners. So civic commissioners are people who are affected by poverty or live within poverty, and a group of people from organisations within the city. And one of the things that we try to do is listen and understand how poverty is affecting people in lots of different ways. And again, it's been an incredibly eye-opening experience. And one of those things is about the institutional way that the NHS works against people who have accessibility needs or other things. And I recently filed a letter from a NHS organisation where it's somebody who'd been sent for an endoscopy, a camera to look into their stomach to make sure they didn't have an ulcer or worse, a stomach cancer or bowel cancer, because they were very anemic. And when I filed this letter, I recognised the name because I referred them, and I thought, oh, it's not them. And this person, they're schizophrenic and they've got a learning disability. And that person hadn't responded to whatever invite was sent out to them from hospital, so they get an automatic discharge. That's it.
Well,
and you think, what have we done to ensure that that person has their needs are met, their needs are understood? Do they have a phone? Do they have an access to the internet? We have lots of services now where when what we hear from Poverty and Truth Commission is lots of people struggle or don't get those messages of opting into appointments. Yes. So people are discharged if they don't opt into an appointment, but that opt-in system is difficult for them to navigate, either through language problems, literacy problems, access to technology problems. And so I think we've got a growing commitment and need to look at that and to actually understand and say, actually, the people who are missing these appointments, and why are they missing these appointments?
Yeah.
Not what can we do to discharge them quicker. That's a person on a cancer pathway. We've just sent a letter in. And so we have systems to try and reduce that. But really, again, if we were really honest with ourselves, how much time and effort do we put into managing what is probably a group of people who need more help?
Yeah.
Bulk systems that the people who've got support, access, family and structures, all those things, internet access, whatever it is, will be able to take on those services more easily than the people who are economically disadvantaged, affected by poverty, learning disabilities, all those things.
It's fascinating, isn't it? And then you might get a really great project somewhere looking in detail about people who are discharged or people who didn't come to appointments and really putting some resource into that. But it's about resources, isn't it? To find out the stories that sit behind the did not attend, or for children, they weren't brought, were they? They didn't have the choice to come.
So these teaching hospitals are doing work around that, and there is a commitment to looking at that, reminding people and phoning people up. But again, it's how much of our resource and energy do we do that?
How much resource, yeah.
I think there is much more we could do. So we code every letter from a child that doesn't attend an appointment in our GP surgery. We put it on a tab to say they've not been brought. But if we to follow that number up, it's hugely.
Yeah.
Sometimes it's indicative of something else going on in the home that we'd want to help and support about. But again, if we really resource that properly, I'm sure we'd identify some real unmet need. And whether that's just about them being able to communicate back with the hospital, say I don't need to come anymore, or whether that's about them saying it's really hard for me to get my child to an appointment, or there are other things going on in my life, like domestic abuse.
Yeah.
And we know about it. I don't think we resource it well enough.
No. I love the work that you're doing, George, of digging behind the obvious or the data or the presentation of whatever it is to find out why. And that's, I guess, a combination of resource and passion and just imagination to do things differently. And it's not so easy, is it, as just doing the set piece, perhaps?
It's not, but as I said, I am passionate about that.
Yeah, and that comes through.
I've also been fortunate, for example, Becky ran a postgraduate diploma in co-production. I was enabled. We started looking at the systemic, how can the system do this? We were supported to attend that postgraduate diploma, but I met Becky, that's where I met her.
Wow, that's great, yeah.
And that has stayed with me. It has led us to be, I think, better leaders.
I'm sure.
Better enabled, better tools, because of the perspectives that it gained.
Yeah.
And that was enabled by people at the time in senior leadership positions who said, I will invest in it.
Yeah.
I'll invest in these people. And so I think there has to be, like everything, there are levels at which you have to enable and catalyse and give energy to at lots of different places, and that doesn't come without everybody contributing to that.
Yeah.
And I think in Leeds we've been blessed by that throughout lots of different organisations, third sector support for giving everybody an equal voice at the table. My fear is that in really constrained economic environments, that gets less focus, less resource, because we're focusing all the resource on managing acute illness or whatever it is.
Yeah.
It's that rationalising at the wrong end. We'll rationalise weight management services, which don't exist in Leeds particularly.
Right.
But we'll continue to prescribe drugs because we have to. And if we don't, we're legally challenged. But nobody legally challenges if we don't provide a weight management service.
Right. Yeah, I remember Becky mentioned that, the cost of the obesity drug and the issues around that compared with helping people have perhaps healthier food or things that might be more preventive.
Yeah.
Yeah.
We prescribe some very expensive cholesterol drugs, which is great because it reduces people's chance of having a heart attack and stroke disease to some degree, but we don't provide enough services that support stopping smoking and alcohol, and we could spend more and more and more on those types of services, but we have to, I'm not blaming anybody, nationally provide a medication that is fiendishly expensive for very few people. And we struggle to be honest with people about this. We spent years in austerity where we said we're in austerity, but you can have what you want from the NHS.
Yes, yeah.
And therefore, the stuff that we don't have to do has got stopped, despite that being the stuff that will help people in the long run.
That honesty thing is the elephant in the room in a way, isn't it? That more and more things are developed that are possible, more drugs, more tests, more scans.
Yep.
And we all want, inevitably, the things that might help us. And the resources, it is that honest conversation, isn't it, about how to balance the money and how to spend it on the things that really make a difference.
And I genuinely don't think that happens anywhere that I see it. I think people talk in hushed whispers around that, but nobody talks openly in the media, amongst politicians, amongst the national language about saying, actually, we need to probably, I'm going to say, stop doing some stuff. And the stop doing stuff is likely to be things that, if it was your family member needing that expensive drug, you would fight tooth and nail.
Absolutely.
To get them that drug. And I understand that, but funding that drug stops us funding a lot of other stuff. And how do you balance that? I don't think anybody's got it. It's such an ideologically difficult question.
But I think it's also very kind of paternalistic. I mean, I've found through my workshops that we have some really difficult topics come up and difficult conversations. And if people actually start to learn about these different issues and the different perspectives and listen to other people, then they become very good at finding a solution together.
Absolutely.
Whereas if you're just told, this is how things are, and other things are swept under the carpet because they're too difficult for you to hear, it's very patronising, really.
Absolutely. Absolutely. And I would really welcome that. And you're right. My experience is when you do talk to people and you listen as well, and people are like, oh, yeah, I get that. That's fine.
And people love being listened to. They really do. It takes an awful lot of that anger and defensiveness out of conversations just to feel properly listened to.
Properly listened to.
So you were talking about the postgraduate diploma that you did on co-production, and I couldn't help but mention that the thing that's actually brought us together really for this conversation is my favourite piece of work that I've been doing for about the last 12 years is to use Who's Shoes in a annual co-production module with each cohort of Darcy Fellows, thanks to Becky Melby. And I love it because I love the session. I love the kind of people who want to learn about co-production and sometimes how out of their normal experience or perhaps formal medical training it is. But I also love how it really sticks with people forever. It really is transformational, the kind of thinking.
Yeah.
And I love to stay in touch with the people who've gone through that program, because they're special, a lot of them are like really pushing the boundaries in so many different areas of healthcare in that rather special way of listening to people and working with them.
And it's interesting. I don't know where the right input that is, but it's done in a postgraduate place where there are people interested and maybe do that, and maybe the undergraduate curriculum isn't quite the right place. I don't know, but I do think every doctor should spend a bit of time in general practice and understanding perspectives. And I think the thing about co-production is that listening and understanding people's perspectives, isn't it? Giving time to that, being really thoughtful around that, but also having some skills to enable that.
Yes, yeah. And not being frightened of it, I think.
The work we do with the Poverty Truth Commission in Leeds is very much that. It is co-production, but lots of the early stages of that are relationship building so that people can be honest with each other.
Yes.
We can hear the truth so that we're put on an even grounding where people can be absolutely honest and we have genuine emotional connections to people so that you're able to empathize and to, do better, do better than previous. And I think, as you said, people who undergo those programs are generally their lives are transformed and they transform other people's lives because their eyes are opened again.
They potentially take it into every conversation in a way, which is an enormous impact, isn't it?
Yeah.
So, George, before we finish, I don't think you've told us yet about your approach to multidisciplinary work, which I absolutely love and wanted you to talk about.
Well, thank you. So, I'm glad you said multidisciplinary work because it should be that. And it is around a multidisciplinary team. And I think sometimes we talk too much about the meetings being a multidisciplinary team. But we are fortunate in Seacroft to have a collective of people, a multidisciplinary team, who largely work around a frailer population broadly, but are absolutely focused on helping patients in the most proactive way they can and stepping into problems and not saying that's somebody else's thing to sort out. And we often think about what's good about it. What's good about it is anybody can turn up and nobody's expected to turn up. So we hold space 8 till 9 every Wednesday morning, and we have them for quite a few years. And because of that, people know where we are, and you can just turn up. It's on Teams. There is an invite, but anybody can come. And we have a very fluid conversation. We invite people to present cases and to ask a question about what they want collectively from it. But, you don't have to email in a week before and get permission and do those things. We quickly go through it and say, who do we need to talk about today? How can we help people? And we have a range of people going from a consultant geriatrician from a teaching hospital, some GPs, some of our care coordinators we've got proactive care coordinators, ACPs, so advanced clinical practitioners from the community sector. We've got a dementia care worker from the mental health trust. We've got some third sector. We have a social worker. So a broad, I've named everyone, I'm going to get in trouble. A pharmacist. I get in trouble for not talking about people. But we have a wealth and a broad view, and everybody's welcome to supporting the families and the people we discuss there. And, our geriatrician can't get there till 8:15. We know that. So we don't talk about, we might talk about something else first that our, hope she won't mind, but our person from the mental health trust has a daughter sat on her knee. She brushes her hair on her way. She's got long hair and she has to brush her hair because she's getting ready for school. Do that. We've got the district nurses already out giving insulin to people on the morning insulins already. And they run in, give someone's insulin, run back, and they've got their phone stacked on the car steering wheel, talking from their mobile phone. And it's what we want is no barriers to entry. So no barriers to patients, no barriers to people. We don't do referrals. So we have a system in which if people think they can help that person or family or carer, we sort that problem between us. And I think for me, that's multidisciplinary work where there is no organisational barrier. People come because it makes them, and we've done some work a little bit, some brief surveys about why do you come? Well, I feel like I'm actually making a difference. I feel like I'm helping patients.
Yes, yeah.
We like sharing, we like talking to people. So sometimes it's just, I just want to share this thing, and that's it. What am I asking? I'm asking, am I do? Is this okay? And everyone's like, yeah, it's all right. It's good. So I am excited by that. I know that it doesn't work well everywhere. There's been years of trying to get teams to work collaboratively across sectors. And I like how it works for us, but that might not work for everyone.
But I think what might work for everybody is the principles. And what I'm hearing is you've created something that's flexible, that fits into people's lives, that's welcoming, that they get something from. They feel that they can dip in, and the fact that you can't make the whole 60 minutes every week doesn't mean that you're a nuisance or difficult. And it really reminds me, George, and I think you'd absolutely love this, and I'd love to invite you. I take part in a monthly kindness conversation organised by Dr. Bob Claber, who was one of my earlier podcast guests, who I've met through the kindness conversation. And it's just the most amazing network. It draws in people from literally across the world. And we regularly, every single month, get Kath Crock joins from Melbourne and Nikki Macklin joins from New Zealand. And by definition, I mean, it's 6:00 in the evening. It's an antisocial time for them, big time. And other people, from America. And Bob did something recently, and it was very similar to what you're saying. Like, what is it? Why do people keep coming? And it was just those same points, really, about how you contribute and get something from it, and you build those relationships. And it's very rewarding, and it's more than rewarding. It's life enhancing in a way.
Yeah, well, I don't want to oversell. If they get value from it, they'll keep coming. And so people get value from it for whatever reason. And it is almost a team hug.
Yeah.
I'm not going to say cringy.
And the fact that can happen virtually is crazy, really.
Yeah, honestly.
And in our case, I mean, in your case, it's people who probably know each other more. And in our case, most of us don't, and then when you do meet people, as I got the chance to meet Kath Crock from Melbourne recently, and, meeting like old friends, it's really, she's been on the podcast series as well. You can feel this network kind of growing.
Yeah.
Yeah.
I would love to come.
So, yeah, a couple of introductions then. I love it when these different threads spark each other and build the networks.
Absolutely. And I think that's the greatest strength comes in networks, don't we? There's no single person, is it? Networks, social networks, community networks, work networks, all those things. And the stronger they are, the more you can do. And it's, again, one of our strap lines, you can only move as fast as the trust allows. And you build trust in networks and relationships.
You do.
And people trust you. You go and do, the reciprocity. Somebody will come and say, I've got this problem. And I'm like, I can go and sort that out for you. That's okay. You don't need to do that. Or that's great. I know a person who can do that. And so the trust comes with real things, doing things for people, or just being kind when they're saying, this is really difficult. And you're like, yeah, this is difficult and it's okay.
Yeah, the conversations we've had around kindness in healthcare have just been extraordinary. I'm sure you'd instantly get what I mean. And I say each month we're talking about different aspects, or perhaps have a different presenter, or somebody just, challenging us to think a bit differently. Very, very powerful.
I like that. It is. But that's equally, it's simple stuff, isn't it? It's human traits.
Very simple, not overthinking it. Just, make things happen for people. And that's what you're doing, George. And, when I said team at the beginning, I used team in the sense of all of that network, collaboration, the people that need to be involved are being involved. And that's special.
Absolutely.
Well, thank you so much, George. It's been such a pleasure talking to you and finding out just, I'm sure, a tiny, tiny sample of what you're getting up to. And I just hope it inspires people to think that they can't copy you because they're not you, but they can be inspired to take ideas and follow some of the principles, I think, of just go for it rather than be too worried about everything.
Yeah. I think you've just got to start sometimes, haven't you? And I'd just like to say, I work with some amazing people who over the years have given me freedom, but also support. And now I hope that we continue to that.
Yes.
Collaborative process with our teams. And I hope that I now try and share some of those freedoms with them to do better stuff.
Yeah, I'm sure you do and you will. Yeah. Well, thank you, George. And it's another contribution to our series.
All right. Thank you so much, Jules. We love this talk. Hopefully we'll continue talking.
Yeah. Okay, thanks. Bye then. Thank you so much for listening. If you enjoyed this episode, it would be fantastic if you would leave a review and a rating, as well as recommending the Wildcard Hooshoes podcast series to anyone who you think might find it interesting. And please subscribe. That way you get to hear when new episodes are available. I have lots more wonderful podcast guests in the pipeline. And don't forget to explore and share previous episodes. So many conversations with amazing people who are courageously sharing their stories and experiences across a very wide range of topics. I tweet as Whose Shoes. Thank you for being on this journey with me, and let's hope that together we can make a difference. See you next time.